I'm Sara Allan. I'm Associate Professor at the Institute of Health Policy Management Evaluation at the University of Toronto, a colleague of Walter's. I'm also the director of the North American Observatory on Health Systems and Policies, and that's a research center and collaborative network. So while we have a base in the University of Toronto, we have collaborators and colleagues across Canada, across the United States and Mexico, and we routinely conduct comparative analyses of pressing health policy challenges within Canada at the subnational jurisdiction level, but also across comparators that are often compared to Canada and Europe, Australia, New Zealand, and across North America. And so in that spirit, we're here to present some of the work that we've been engaged in over the past few months to really understand what we can learn from other jurisdictions that have had similar aims and objectives to what we have across Canada to improve integration, but have a bit more experience, several more years of experience. And so cautionary tales, lessons learned on what has worked and what has not worked is sort of the thrust of this project. So I'll turn it over to Dr. Stephanie Tan, who's going to lead us through a sort of 10-minute overview of the results, and then look forward to the discussion today. Thanks again.
So we conducted a literature reviews to start this off and to identify innovative models of care occurring in these 4 countries. And we held semi-structured interviews with 16 informants from our 4 jurisdictions over the summer and fall of 2023. These interviews allowed us to validate and expand on the learning from the literature review to identify promising policy supports for the implementation of different types of integrated care models of care across Canada. So across our 4 international case studies, we find that all jurisdictions are pursuing greater coordination or integration of care to improve care effectiveness and efficiency for patients. This slide provides some context about the reforms in each of the 4 countries that we examined in our study. First off, in England, there has been a focus on devolving decision-making to foster more locally grown policy development through legislative reforms and a series of overlapping pilots for integrated care. These have been intended to promote local decision makers to become more responsive to the population, but they have struggled against wider and often competing pressures for austerity in public services. Similarly, in Germany, we find there's experimentation with different population level approaches throughout the country. For example, in the Black Forest, there were selective integrated care contracts between health insurance funds and providers to generate share savings. There's also interesting experimentation through the health kiosk approach, which is a local spot to access health and social services support, particularly in underserved areas. So we see this in a socially deprived district of Hamburg, and also it's currently being trialed in Cologne. In the Netherlands, we find there are several financing and workforce tools in use as policy levers to pursue more integrated care pathways. These are largely at the subpopulation level, such as local neighborhood teams in The Hague, addressing chronic conditions through disease management programs, or targeted interventions at maternity care. In the United States, we find that accountable care organizations focus on better connecting primary care providers through community, primary, and allied health professionals by drawing on legislative supports and requiring ongoing evaluation as an accountability mechanism. So the first of the 5 policy supports I'll be discussing today is that of governance and partnerships. Across all jurisdictions, we find legislative reforms are important in enabling new partnerships or service innovations, but policymakers can further facilitate this process by setting out guidelines or expectations about how actors at all levels can practically collaborate across healthcare and the social and community care sectors. They can do so by setting out clear objectives, which can be aligned throughout the implementation process, for example, by setting out clearer logic models. We also find it's helpful to identify and empower local policy entrepreneurs. For those not familiar with the term, policy entrepreneurs refers to actors that are inside or outside of government that can take advantage of policy windows to put issues on the political agenda. Our informants identified specific individuals as policy entrepreneurs in England and in Germany that brought about innovative ideas and drew together necessary actors to enable the policy process in a top-down or in a bottom-up implementation way. It should be noted, however, that the policy processes that are often credited to specific policy entrepreneurs can encounter issues later on when trying to scale or replicate a project outside that initial site. This can apply both domestically and internationally. Next, we'll discuss the role of financing as our second policy forward. Across all jurisdictions, we see a range of initiatives to align financing, such as aligned purchasing, pooling, pooled budgets, or pilots. From England, we find evidence from the evaluation of the Better Care Fund that pooled budgets did work to enable joint decision-making and better coordination of care. However, it should be noted that this is a very small-scale example, but informants reported it better facilitated better collaboration when sites overlap with other concurrent pilots, such as the Vanguard New Care models or the Integrated Care Pioneers. From the literature, we find that bundled payments in the Netherlands or disease management programs in Germany are quite widely discussed, but several expert informants said that these disease-specific financing streams can be insufficient to overcome fragmentation within the health system and could even exacerbate it. Instead, they suggested the policy should focus on reforms for systems of care and better coordination. Lastly, in financing, new pilot initiatives are very welcome because they enable experimentation with innovative new models of care. But it's also important to have a plan for continued funding or practical support for successful pilots. For example, we find that the German Innovation Fund is a really interesting example where pilot funds include a requirement for a program of evaluation as a mechanism to extend funding for successful projects rather than having them end at the end of a set period of time and have a lot of that policy learning not go forward or be applied further. Our next policy support is that of workforce and staffing. We find evidence across the European comparators that dedicated funds that can contribute to bring on a new individual, for care coordinators, or an embedded researcher to act as a knowledge worker was really important. Informants we spoke to described knowledge workers as individuals responsible for communicating about or facilitating new models on the ground. Second, informants in multiple jurisdictions said it was important to have a physical space available for training or meetings to enable collaboration between partners in the health or social sector. Informants said it was important to have a place to meet that wasn't necessarily on health territory to discuss how collaboration could be improved or how patients needing coordinated care plans could proceed. Our informants actually noted that virtual options during COVID-19 pandemic seemed to even the playing field to facilitate more distribution, to facilitate what felt like a more equal distribution of power between the sectors, so that there were several examples, so that meetings were no longer 10 or 30 people crammed into a single clinical room trying to see one laptop, which is a handful of people from the social or community sector. The next policy support for discussion is that of data sharing and use. This remains a significant issue for policy implementation across all jurisdictions. For example, our informants reported issues with data sharing across primary, secondary, and community care, especially where systems couldn't share information across settings with ease because they were using different electronic medical systems or records. And sometimes there was quite mundane barriers such as metric system incompatibility with a community care setting using grams while a secondary care setting used kilograms, so that you had to input data again. The other points on this slide, I'm going to touch on in more detail in our policy challenges. Our last policy support is that of equity initiatives. Across all jurisdictions, we find strong interest in addressing socioeconomic or racial inequalities at the national level, but in practice, projects are often locally determined and vary tremendously in scale and scope. We argue that policymakers do play a really important role in setting the agenda for equity-deserving initiatives, but could do more to support implementation by outlining necessary steps or a timeframe for those initiatives to proceed. Overall, we find there are a range of policy supports in practice, but we want to highlight four key challenges to policy implementation before we move into our policy implications. So first, we find across all jurisdictions that there are entrenched power disparities between the health and social care sectors that pose significant challenges to achieving meaningful integration at scale. Integrated care initiatives have to consider existing power relationships between sectors and institutions, as well as their values and interests. Our key informants told us that power imbalances between hospitals and community providers could really impact the success of integrated care initiatives, particularly because they tend to focus on driving care outside of hospitals into community. So there can often be less buy-in from hospitals to participate in such initiatives. However, the Netherlands offered an interesting counterexample where they addressed this imbalance by moving long-term care within health insurance packages rather than leaving it as a responsibility for local municipalities. Second, informants emphasize the importance of monitoring and evaluation of integration initiatives. Often there's a reliance on proxy measures, such as emergency department usage, because there are no clear established measures for assessing integration success. So all jurisdictions have struggled to qualify progress beyond unplanned emergency department use or shared savings amounts. So more accountability mechanisms or requirements for community engagements or appropriate use of clinical audits for new pathways of care can have the potential to foster the development and of evidence and better data use to validate both successes and failures. Third, data sharing and use remains a persistent challenge across all jurisdictions, particularly in our European comparators. These range from practical issues of data compatibility to more serious issues regarding data transparency and the ability to share data for robust or independent valuation for pilot initiatives. Lastly, policy transfer of successful models of care between and within jurisdiction is harder than it seems. It's really important from informants and our analysis to focus on both successful support, such as the role of knowledge brokers and care coordinators, and to enable appropriate funding to allow them to support implementation and scaling if that is the goal. But informants also suggest that we should focus equally on failures alongside successes, draw out lessons for other jurisdictions so that failure isn't put in silo or seen as a negative. There can be policy learning from both ends. So overall, to close out, I want to draw out some key learnings from our work to identify some potential insights. Given the time constraints, I'm only going to draw out two of these. But first, we find that legislative reforms do enable the development of partnerships at the macro level, but policymakers can further support this process of implementation. So they can do so through the development of logic models to clearly set out how new models of care can be actualized and what people in the system can actually practically do at each level of service delivery to enable the implementations of these new models of care. And second, policy guidance for integration really focuses on the importance of interdisciplinary teams and collaboration, but there were quite limited examples of support for actual workforce improvements, such as funds for dedicated staff members, overseeing projects or project managers, or dedicated meeting space. Where these did occur, informants knows that these really were able to facilitate and manage implementation alongside success. So thank you for your time today, and I welcome further comments or questions during our panel today.